Hello, good afternoon.
Hello, ma'am. Good evening. Am I audible, ma'am?
Hmm?
انت بتتكلمي من هناك. وطي الصوت بتاع الموبايل او اقفلي الموبايل خالص، مالهاش لازمه بقى، ما تتكلميش منه.
Okay. Thank you all. We'll start a webinar in a couple of minutes. Good evening, ma'am.
Hello, good evening.
Good evening, ma'am. You're pretty audible. Before we start a session, just 2 minutes of self-intro session, ma'am. I'll be just introducing and we'll start with the topic, ma'am.
Can I start now?
I guess you have connected with the other device, ma'am, so the echo is coming. Okay. Very good evening, everyone, and welcome to today's session, The Future of Endodontics, Exploring Vital Pulp Therapy Techniques, organized by Apatento. My name is Josha Roshni, and I will be your moderator for this highly anticipated event. We are excited to dive into today's topic as it explores the cutting edge advancements in vital pulp therapy, a critical area for the future of endodontics treatment. I would like to extend a special welcome to our distinguished speaker who will be guiding us through this insightful journey. Our speaker today is a renowned figure in the field of endodontics. We are honored to have with us Dr. Mai Hamdi Ragat, an associate professor of endodontics at Faculty of Dentistry, Suez Canal University, Egypt. Dr. Ragat has made remarkable contribution to the study, practices endodontics, particularly in the area of vital pulp therapy, and her research and significantly influenced clinical practices worldwide. Her expertise and insights are invaluable, and we are eager to hear more from her. Before we begin, a few housekeeping notes. This session will last for about 1 hour, and I encourage every participant to feel free to note down any questions. We will have a Q&A segment at the end where you can either unmute yourself or submit your questions via chat box if you are joining us online. Without further ado, please join me in welcoming Dr. Mai Handi Ragat as she takes us through the future of endodontics, exploring vital pulp therapy techniques. Ma'am, over to you, please.
Good evening. First, I would like to thank you for this nice presentation about me. I am May Hamdi, an associate professor of endodontics, Faculty of Dentistry, Suez Canal University. And today I will talk about the future of endodontics, exploring recent vital pulp therapy. I would like to simplify and compare the concept of vital pulp therapy from today than tomorrow, inshallah. Dental pulp plays a vital role in tooth development as it harbors progenitor many stem cells that proliferate and differentiate into dentine-secreting odontoblasts. Regeneration of the pulp-dentine complex holds the promise of extending the function of the natural dentition, particularly in cases where traumatic injuries to permanent immature teeth halt root maturation and full development. There are many objectives about vital pulp treatment, which is to create a state that enables the formation of hard tissue barrier and the recovery of tissue, preserving the functionality of the vital tooth. We all know the importance of the dental pulp as it has many functions, which are initiative and formative, also nutritive and defensive and innervation functions. So we have to protect it from any types of irritants, such as chemical or mechanical irritants. So a general rule, or as a general rule, pulp is a small tissue with a big issue or with an important function for the tooth. Pulp protection means restoring the tooth's own heartbeat. So the pulp considered as a heart for the tooth. The outcome of the vital pulp therapy depends on proper diagnosis of the cases and selection of restorative material and complete elimination of the microorganism. All of us know the importance of the disinfection of the pulpal field on the outcome of the vital pulp therapy. The indication of vital pulp therapy, there are many indications, which is the inflammation, reversible inflammation of the pulp, and absence of any spontaneous pain or any resorption or periradicular lesion all around the roots of the tooth. But nowadays, and after many studies, they concluded that there is no correlation between the sign and symptoms of the patient and the real health states of the pulp. Pulpal health should be confirmed preoperative by pulp sensitivity test and intraoperative by the presence of vital tissue after exposure. And there are many contraindications for vital pulp therapy, which is teeth exhibiting spontaneous or constant pain and restorable crown, and continuous uncontrollable pulp bleeding for more than 5 minutes. Changing the concept about pulpal inflammation, traditional preoperative spontaneous or illicit severe pain and carious pulp exposure, which is an indicator of irreversible pulpitis. But nowadays, the inflammation limit to the coronal pulp next to carious lesion, and the majority of the pulp are inflamed and viable. Traditional, they go on to perform root canal treatment, make the tooth non-vital. But nowadays, removal of the extensively inflamed pulp tissue can allow the remaining uninflamed pulp to be preserved, forming part of a regenerative endodontic approach. In the past, vital pulp therapy confined to direct pulp capping and indirect pulp capping. But nowadays, forming part of a regenerative endodontic approach, vital pulp treatment aim to induce the natural regenerative ability of the dental pulp in order to repair the tooth, as indirect pulp capping, direct pulp capping. Let's start to know many about the procedure or the physiology of the dentine when challenge the carious lesion. Many physiological process to protect the pulp from any injury. So the formation of reparative dentine or reactionary dentine. This study performed in 2016 cellular differentiation of migrating progenitor cell occurred under the influence we form new odontoblast-like cells. All of us know that the dentine harbor many biological molecules to protect the pulp from further injury due to caries or trauma. Reactionary dentine formed due to the activation of a new odontoplast-like cell, not the odontoplast. While the reparative dentine, the activation of the existing odontoplast cell. So the dentine formed after the injury is a dentine-like structure or dentine-like tissue, not a dentine, as the formative cell is an odontoplast-like cell, as the odontoplast damage due to many injuries. So the tissue that formed from the odontoplast-like cell is a dentine-like tissue, not dentine like the primary dentine. There are many studies observe the success rate of direct pulp capping with MTA and give an success rate very high and protect and preserve the vitality of the remaining vital pulp tissue. Also, I published many articles about the physical properties of different pulp capping and histological analysis of their effect. We concluded that nano modification of MTA and nano modification of bioactive glass enhance the dentine bridge thickness, but of inferior quality than MTA and bioactive glass. Still, these studies conclude and confirm the theory that I still discuss with you, which is the performed or formed material dentine-like tissue, not a dentine, because the formed cells is an odontoplast-like cells. Here there are many contraindications for the vital pulp therapy after excavation of the carious dentine and pulp is exposed. We know two important factor, which is the characteristics of the blood oozing from the cavity. The blood oozing from the cavity reflects the health status of the body, of the pulp, which is the heart of the tooth. The color of the blood is an important indicator about the vitality of the pulp. Here, the photo number A, the pulp tissue is dark and avascular. B, which is a contraindicated for making vital pulp therapy. So we need to more and more excavate necrotic pulp tissue to obtain an healthy vital pulp to preserve it. Photo B, superficial pulp tissue at the exposure site deconstructed and avascular. Surrounding dentine still very soft and carious. C, close-up of the major exposure in B, and D, exposed pulp tissue is avascular, which reflects that this tooth or this pulp is non-vital, surrounding by reddish pulp tissue. Photo F, dentine shapes displaced into avascular exposed pulp tissue. Photo G, several dentine fragments displaced into a barely vascular pulp. The surrounding dentine is still soft. Appearance of case in G after removal of soft dentine and partial pulpotomy. The surgical wound appeared clean after hemostasis. Many direct pulp capping material mainly is a hydraulic calcium silicate cement which induce the dental pulp stem cells occurred or present in the dental pulp to differentiate into odontoblast-like cells to prevent the exposure of the pulp and to protect the pulp from further injury. Another publication for me, which called histopathological evaluation of human placental extract as a direct pulp capping material in dog's teeth. And this current research evaluates the histopathological pulpal alteration in dog's teeth, follow direct pulp capping using mineral trioxide aggregate and human placenta extract. And we concluded that the human placenta extract is a promised pulp capping material which is induced less intense chronic inflammation with thicker dentine bridge formation in comparison to MTA. And still, the dentine formed is a dentine-like structure devoid of the dentinal tubule and completely different from the primary dentine. Follow the coronal removal of carious dentine. Still, I make exposure, and still there is persist bleeding for more than 5 minutes, which is an indicative of further inflammation in the pulp, which necessary to remove it. So I'll go to do pulpotomy, which is elimination or complete removal of the coronal pulp tissue to preserve only the vitality of the radicular pulp. Here, after excavation of the carious dentine found in the coronal pulp tissue and ensure that the remaining pulp is vital, is healthy. So now we decide to perform pulpotomy to preserve the vitality of the radicular pulp. But if there is a continuous bleeding, the cavity oozing much more blood, so I'm obligated to remove more and more pulp tissue to remove the inflamed pulp. Vital pulp therapy for permanent teeth with diagnosis of irreversible pulpitis. Here is permanent teeth with carious pulp exposure and clinical diagnosis of irreversible pulpitis. So we have choices for vital pulp therapy: partial pulpotomy, full pulpotomy, or root canal treatment. The main indicator for select the proper choice for vital pulp therapy is the health of the pulp states. I disinfect it with 1 to 3% sodium hypochlorite for hemostasis, as full concentration of sodium hypochlorite may cause injury to the stem cells and make complete disinfection, but unfortunately injury the stem cells. Here, bleeding control in 10 minutes, so I decide to perform partial pulpotomy. If yes, I'll make 3 millimeters of calcium silicate cement and permanent restoration and do follow-up. If no, so we need to remove more and more pulp tissue to eliminate the inflamed pulp tissue remained in the exposed cavity and make full pulpotomy. After removal of complete coronal pulp tissue and make deroofing of the coronal pulp tissue and still there is profuse bleeding for more than 10 minutes, then I decide to perform root canal treatment? Here is a question. Can root canal treatment help save an injured tooth that is still growing? Huh. What about the what about the this question? Anyone has a response? Can root canal treatment can save or be a proper choice for a tooth that is still growing with an open apex? Can I do root canal treatment for a tooth still grow? Okay. One of the principal tenets of endodontics is obturation of the entire root canal system three-dimensionally, with emphasis open obturation of the apical third of the root to ensure that I make 3D seal for the pulp space to eliminate as much as possible the reinfection coronally and apically. This is achieved by an apical preparation which create an apical construction that facilitate adequate condensation pressure in three-dimensional obturation. However, open apex precludes the achievement of this goal. Open apex faces a lot of problems. In these canals, the larger apical diameter versus small coronal canal diameter makes debridement very difficult. Lack of an apical stop makes the obturation is impossible. Thin root canal wall become prone to fracture easy. Indeed, the most common cause of treatment failure is cervical fracture. Forming part of a regenerative endodontic approach, again, here is an epexogenesis. Epexogenesis done in a tooth with open apex, as I show here, as this tooth immature with open apex. And I said before that root canal treatment is impossible for this root due to two major reasons: lack of an apical stop and very thin dentine wall, which permit easy the tooth to be fractured open mastication. So, in the past, we perform an epexogenesis, which is induce the Hertwig epithelial root sheath of Hertwig to make an continuous formation of the tooth with cementum to close this apex and preserve the vitality of the radicular pulp. Nowadays, we perform a revascularization step, which is performed in totally necrotic tooth in order to regain the vitality of the tooth by induce the stem cells which present in the periradicular tissue to differentiate and do another pulp-like tissue inside the root canal by the presence of three major triads, which is growth factor, which is present inside the dentine, and stem cells found in the periapical area, and the scaffold or the extracellular matrix, which is the pulp space occur in the tooth. There are many scaffolds used in the pulp regeneration. Some of these are natural polymer like chitosan and hyaluronic acid, collagen, and fiber, while others are synthetic polymers as polylactoglycolic acid, polylactoglycolic acid. And there are many studies who investigate the effect of this scaffold in pulpal regeneration with stem cells and the growth factor. This study, known as gelatin mesacryl alginate cord shell microcapsule as efficient delivery platform for prevascularized microtissue in the endodontic regeneration. Bone healing and root development not necessarily confirm the formation of the tissue closely resemble pulp dentine complex within root canals. That I said before, that all the regenerative tissue today is about a dentine-like structure or pulp-like structure in regenerative endodontics. In fact, the histological examination of the tissue formed inside the root canals of the teeth, treated with any regenerative procedures, reveals the apposition of cementum-like tissue, which is responsible for canal narrowing and increase in the length of the root. So true pulp regeneration remain nowadays a clinical challenge. Also, the use of the antimicrobial agents has two parallel paths, as we need complete disinfection of the pulpal field to eliminate as much as possible the microorganism, which is a true enemy for the endodontist. And still, we need the stem cells or the progenitor cells found in our field to survive, as we need to activate the stem cells to differentiate into the cells which is to form the tissue that I'd like to form inside my field. There are many antimicrobial therapy used in regenerative endodontics as triple antibiotic paste, but the triple antibiotic paste found to have a major disadvantage, which is the discoloration from tetracycline. Triple antibiotic paste consists of mixture of triple antibiotic, ciprofloxacin, metronidazole, and tetracycline. After the disadvantage of triple antibiotic paste, they exclude the tetracycline to avoid any discoloration and use of only double antibiotic paste. And there are many case reports which indicate the high rate of success of the double antibiotic paste used in regenerative endodontics. And there are many intracanal medicaments for regenerative endodontics, in addition to triple and double antibiotic paste, calcium hydroxide, and formicresols in the past. I published an article about the effect of different intracanal medicaments on dentine microhardness and dislocation resistance of MTA during regenerative endodontic treatment. And the results show that double antibiotic paste and calcium hydroxide group of intracanal medication and time interval decrease the effect on dentine microhardness and MTA dislocation resistance of the MTA. Bioactive glass intracanal medicament increase in the dentine microhardness and MTA dislocation resistance. The time factor display a significant effect on dentine microhardness and dislocation resistance of MTA. So we recommend that we apply the intracanal medication for only 1 week for making complete elimination of microorganisms. Recently, many techniques for the delivery of intracanal medication inside the root canal to perform a regenerative endodontics, also senses of triple antibiotic eluting nanofiber, addition of low antibiotic concentration to preserve the stem cells. As that I said before, that high antibiotic concentration have an advantage to eliminate the microorganism, but hazards for the stem cells. So senses of triple antibiotic eluting nanofiber based on addition of low antibiotic concentration and slow drug release. Also, recently, there are many advanced disinfection techniques for elimination of the microorganism found in the root canal treatment, such as use of sonic and ultrasonic systems, which is release acoustic microstreaming, which is very harmful to the microorganism through cavitation. Use of photon-induced photoacoustic streaming, example, area laser, help in eliminating as much as possible the microorganisms found in the root canals. Multisonic disinfection system also give a good result about the regenerative endodontics when used inside the root canal as an intracanal medication. The use of nanoparticle for elimination of the microorganism also has a very good result for obtain clean fields. Also use of photodynamic therapy with reactive oxygen species in regenerative endodontics. Besides the stem cells and the growth factor which present inside the dentine, scaffold is necessary for the regenerative endodontics. There are many scaffolds, which is other natural, biological, and others are synthetic or artificial, as blood clot platelet concentration, as PRP or PRF, platelet-rich fibrin, used as a natural biological scaffold, polymer as collagen, chitosan, and dentine matrix, while synthetic scaffold as polyglycolic or polylactic acid. Regenerative strategy for dental pulp regeneration, use of 3D nanofibrous scaffold for enhance the differentiation of stem cells to make dental pulp like tissue. Another publication entitled Evaluation of Dental Pulp Stem Cells Behavior after Odontogenic Differentiation Induction by 3 different bioactive materials on 2 different scaffolds. And we concluded here in this article that polylactonic acid with nanochitosan, magnesium hydroxyapatite scaffold, better odontogenic differentiation effect on the cultured dental pulp stem cells. Combination of this scaffold and bioactive material affect the induction of dental pulp stem cells into odontoplast-like cells. Again and again, odontoplast-like cells, not odontoplasts. Nowadays, any injury and after activation of the stem cells present in the pulpal field result in odontoplast-like cells and formation of dentine-like tissue. MTA is the best bioactive material for inducing odontogenic differentiation of culture dental pulp stem cells compared to the antibodies and TC. Also, polylactoglycolic acid microsphere used as a scaffold and give a very good result in regenerative endodontics. So we need in the future next generation bioactive capping materials. Currently, as I said before, hydraulic calcium silicate cement as an NTA used to stimulate the release of bioactive dentine matrix component, which has an important role in increased migration, differentiation, and biomineralization of the dental pulp cells. Currently, no pulp capping material specifically target the inflammatory process. So, in the future, gene therapy make a very important pathway in the vital pulp therapy in order to target the inflammatory cells to avoid the damage of the odontoblast or activation of the damaged odontoblast to make stem cells to form the exist odontoblast, which is an odontoblast with a characteristics of the odontoblast cells to form dentine tissue, not dentine-like tissue. So the gene therapy targets the inflammatory process and eliminate the inflammation to avoid damage of odontoblast or to differentiate the stem cells into odontoblast cell, not odontoblast-like cells. Recently, epigenetic therapeutics is a recent line of treatment for vital pulp therapy. First, epigenetics, the study of a change in gene function that are mitotic or meiotically heritable, not entail change in the dental and change DNA sequence, and has gradually become a research hotspot in the recent decades. Epigenetic regulation can influence the gene expression without modifying the primary DNA sequence. Many genetic therapy, such as histone deacetylase inhibitor, which used recently in vital pulp therapy. Here there is a caries and biofilm. After removal of caries and biofilm, application of histone deacetylase inhibitor, which is an epigenetic therapy, reduce the inflammation and increase the mineralization and the stem cell migration and enhance the angiogenesis, so the dentine formed after the application of the epigenetic therapy is a dentine tissue formed by the odontoblast. The epigenetic factor, many epigenetic factors regulate the dental mesenchymal stem cells, and many dental mesenchymal stem cells, such as sheds and bone marrow stem cells and stem cells for apical papilla and dental follicle stem cells, and enhances the differentiation of the dental mesenchymal stem cells into odontogenic differentiation, osteogenic differentiation, chondrogenic, myogenic, angiogenic, and adipogenic differentiation. And many studies investigate the effect of histone deacetylase inhibitors and DNA methyltransferase inhibitor, which is used also in the treatment of cancer disease, who target the inflammatory tissue on mineralization and differentiation in dental pulp cell population. And finally, we conclude that more studies are needed to determine the long-term success of vital pulp therapy and develop objective diagnostic measures for indicative pulpal condition. Nowadays, we use a microscope and many biological indicators for proper diagnosis of the health status of the body. Current evidence suggests that the vital pulp therapy can successfully perform in immature and mature permanent teeth with reversible and irreversible pulpitis when follow strict asepsis protocol, included dental dam placement, complete caries removal, confirm pulp health by achieve hemostasis for less than 10 minutes, and direct observation of the exposed tissue under magnification, and using biocompatible calcium silicate cement provide immediate and seal high quality restoration. Regenerative endodontic treatment aim to help in true pulpal degeneration and re-establishment of the pulp-dentine complex, which lead to revitalization of the tooth with proper pulp structure or with proper pulp tissue, not a pulp-like tissue, and it may be an alternative treatment option in the management of root resorption, especially when the prognosis is deemed poor because of the severe resorption. Thank you, and I hope that it's a lecture full of many and helpful information for you.
Oh, thank you. Thank you, ma'am. Thank you so much for that enlightening presentation. It's clear that vital pulp therapy is set to play significant role in shaping the future of endodontics. Now we'll move on to our Q&A session. If you have any questions for Dr. Ragad, please feel free to raise your hand or type your question box in the chat box. We'll try to get through as many of questions as possible in the time we have.
I didn't understand what you said.
The floor is open for the questions. All the participants who are ever having any other questions can drop your queries in the chat box or raise your hand.
Yes, madam, we do have, but I'm not very sure if they assist in that also. Since the nodal office will be connection with the details of those channels. So
I can't hear.
So
I guess every participant was very overwhelmed, ma'am.
I noticed a question, which is it possible if he could receive the presentation? Of course, I can send it with pleasure.
yes, but now I can review it tomorrow only, madam, since
The floor is open for the questions. Participants, kindly drop your questions in the chat box or either raise your hand. Ms. Samiha Maunuddin, if you could raise your hand, it would be helpful so that we could unmute you. Yeah, Ms. Samiha Maunuddin, you may talk now.
Good evening. Thank you, Dr. May, for a very insightful presentation. lot of advances I could see in the future, but at the moment, how practical it is in the present scenario, present day. How much
Can
can
you
we
raise your
implement?
voice, please? I can't hear well.
You can't hear me? 1 minute. Now, can you hear me, doctor? Hello.
No, I can't hear you well. Can you raise your voice, please?
Can you hear me now?
Okay.
You can hear me?
Yes.
Thank you so much, doctor, for the very insightful presentation. I
Many
just
thanks.
want to know, with the biomimetic dentistry coming in, they suggest us not to remove the complete caries, to remove the caries only from the surroundings. If it is a indirect pulp capping, for example,
Okay.
what is your opinion on it?
First, first I should make a proper diagnosis for the health
Mm-hmm.
state, and after I decide to make
Mm-hmm.
indirect pulp capping, after complete excavation of the caries, and so I notice that
Mm-hmm.
after this layer, I'll make exposure, and there is
Okay.
a soft carious dentine. So I prefer to stop doing excavation. I put
Okay.
hydraulic calcium silicate cement and
Mm-hmm.
tightly seal permanent restoration, and I will make a proper follow-up after doing, of course, a proper radiograph to ensure that there is no apical radiolucency around the root or any investigation or any signs about irreversible pulpitis.
Mm-hmm.
So I prefer to stop
Mm-hmm.
excavate the soft carious dentine, as we know, all know that the acute phase of the caries always not contain microorganisms, only contain bacterial pulp products. So this layer is disinfected already. So I depend on the healing power of the pulp to perform the reactionary or reparative dentine that I said before.
Follow-up will be after how many weeks?
First, I do follow-up after 3 weeks, and then after 2 months, 6 months, and 1 year. Every time I'll call the patient for any sign and symptoms and perform radiograph to ensure that the dentine formed beyond the restoration that I put it, and absence of any periapical radiolucency or any resorption, which is a sign of an therapy failure.
Okay. And can we implement the same thing in primary teeth also, in deciduous teeth? Indirect pulp capping, does it really work in the primary teeth?
Okay. Primary teeth, we all know that there is minimum thickness of dentine, of enamel. The child go to the clinic with an already pulp, sometimes very huge pulp exposure, and which is infected with microorganisms, which decrease the success rate of the vital pulp therapy. While the child go to the dental clinic with a very dental caries or very small pinpoint exposure, which is very rare, sometimes we can make a choice for vital pulp therapy to preserve the vitality of pulp tissue. As I said before, that to restore or to preserve the vitality pulp tissue is an important issue.
Mm-hmm. Okay, doctor. Shukran.
Thank you.
Okay.
There are three more questions in the chat box, ma'am. Like, what is the difference when it comes to revascularization between permanent and deciduous teeth?
Revascularization of the deciduous teeth.
Difference, what will be the difference between revascularization between permanent and deciduous teeth?
Yes, I am with the revascularization of the deciduous teeth to preserve the deciduous teeth as a space maintainer, but the anatomy of the deciduous teeth, the curvature of the root, make this procedure very difficult.
Okay, ma'am. Thank you. And the next question is, can teeth with periapical lesion be treated in the same manner?
I can't hear this question. Please again.
Can teeth with periapical lesions be treated in the same manner?
Yes, we can do revascularization even as the presence of a periapical or a huge periapical lesion. The main idea is how can I eliminate as much as possible the microorganism found in the periapical tissue, and then how can I stimulate the stem cells which found around the root to proliferate inside the root canals and make pulp tissue inside the root canal and make revitalization again of the tooth.
Okay, ma'am.
The main concept is the elimination of the microorganism, complete disinfection. Disinfection, as I said before, make with calcium hydroxide, intracanal medication, double and triple antibiotic paste.
Okay, ma'am. And the last question is, if when they are doing the follow-up, will they have to do the vitality test?
Only cold test is more a specific sensitivity test, not a vitality test. Vitality test, I test the blood circulation which enters the tooth. That I can't make due to the very high cost of the device which measures the vitality of these tools, as we know, laser Doppler flowmetry and pulse oximetry, which is more accurate. Just I do sensitivity tests, which is test the sensitivity or the neuro supply of the tooth. All I do is a cold test, which is an essential test for guide me about the result or the outcome of the vital pulp therapy.
That's it, ma'am. Unfortunately, we are running out of time, but this has been an incredibly informative session. Thank you again, ma'am, for sharing your knowledge and expertise with us today. And thank you all of our attendees for joining us and for your thoughtful questions. We hope you found this session valuable and it has given you new insights in the future of endodontics. Please be sure to stay connected with Appetendo for future events and update. Have a great day ahead.
Okay, many thanks and hope that I see you soon.
Thank you, ma'am.
Thank you.
All the participants, I request everyone kindly fill the feedback form. The certificates will be issued in a week. Thank you, ma'am.
Many thanks for you. Many thanks.
I repeat again, all the participants will receive a certificate in a week. Kindly fill the feedback form. And we have given you our upcoming conference link also. You may visit and know our future events. Hope we will see all you again in our future webinars and conferences. Thank you.
Thank you.